name is Miranda and I'm a second-year trainee clinical psychologist. Welcome to today's episode of Debate Not Hate, the series where I give you my thoughts and opinions on current issues in psychology, and you are very welcome to have your own. Today's topic is going to be on the subject of can therapists do harm, which I think for many of us therapists can make us feel a little bit like... Because so many of us get into this line of work because of the prospect that we might be able to help people and do good. So the very notion that we might be doing quite the opposite is, it's difficult to sit with, to be fair, but just because conversations are uncomfortable doesn't mean that we are allowed to avoid them. And I think actually talking about this is so important because if we're not aware of all the ways that we might do harm, how can we possibly avoid it and make our practice better in the future? Now, I don't know about you guys, but I feel like my education on this subject has been really limited to our code of ethics and our guidelines around good practice, which is fine, but I don't think they do a particularly good job of addressing the more nuanced and subtler aspects of harm in therapy. And this is where the University of Twitter comes in to save the day, as per always. Now, I have learned so much from listening to other people kind of talk on the subject and share their resources. So I'm going to try and synthesize all of this in today's video. So these are the topics that I'm going to be touching on. If there is a particular issue which speaks to you more, feel free to jump around the video, and I'm also going to link all the resources and papers that I mention in the description box below, so please do check them out. Cool! With all of that covered, let's jump straight into it. The power differential is a good place to start, in my opinion, because it literally underpins absolutely everything when we're thinking about the harm that can potentially be caused by therapists. So this is the idea that intrinsic to that therapist-client relationship is going to be a power imbalance. For lots of reasons, but here are a couple. Number one, the client is help-seeking, whereas the therapist is help-providing. Number two, the client is entering into that relationship potentially at a really vulnerable and sensitive time of their life. Number three, there is a certain status that comes with being a therapist because of your education, your qualifications. People might refer to you as doctor. And number four, the relationship is just super one-sided. So clients will come in and divulge lots of personal information, whereas it's the expectation that the therapist will hold back, be a blank slate. So I think all of these factors combined, and many more, mean that wittingly or unwittingly, because the therapist holds more power in that situation, they can dominate the relationship, and this can lead to a risk of them kind of imposing their own views and perspectives onto the client in a way that has absolutely no personal meaning for them and can really undermine their experiences. So how do we protect against this? So something that my current supervisor says at the moment, which I really like, is that as clinicians, we need to hold on to our power lightly. So what this means is that we don't put our knowledge and expertise on this pedestal. And that's good for two reasons, because A, it acknowledges that we don't hold this like special objective truth, that our perspective is just one of many valid perspectives. And also B, I think it really puts us in a much better position to accept constructive feedback and criticism from our clients without sort of undermining who we are as people and then needing to kind of assert our expert position on the other side because we feel insecure. And so I think at the heart of this is really this process of encouraging feedback from the people that we work with. And I think, to be perfectly honest, while I obviously set this out at the beginning of sessions and things like that, for a long time I don't think I gave it the airtime they actually needed, because, you know, in my mind I was like, well, you know, I'm young, I'm early in my career, like people won't feel uncomfortable about challenging me, which I think is actually super naive. And I think the real time where I started to develop these skills was on my child placement, because I was like, okay, in this situation, I'm definitely the adult in the room. And so I really spent so much more time, like over and over again, saying things like, hey, you know, my job here is to understand things from your perspective. And if I'm saying things that don't sound like you or don't sound quite right, that means I'm going off on the wrong path. Please do me a favor, help me out, stop me there, because I need to come back and do a better job of understanding. And I think just doing that process, it just reminds me like how important those conversations are, you know, not only in the topic of minimizing harm, but also in tempering my own ego. Feedback is key. As therapists, we're all trained in particular therapeutic approaches, and it just seems to me that all the approaches that we learn at university and feature in our guidelines, like, I don't know, they just seem to have a couple things in common. What is it? Very Western-centric, okay? And this is not to throw any shade on these particular approaches, because honestly, I think they can be really useful for particular people experiencing particular difficulties. However, I think it's more about recognizing the limitations of all of these therapeutic approaches coming from a similar lens, a similar perspective, and designed to serve a certain group of people, and just how these might not be the best frameworks to understand and capture people's experiences of things like race and intersectionality. So I really loved this tweet from our first Twitter guest lecturer, Connor, who basically highlights how each of these modalities could potentially run into some slight issues with clients who are bringing their experiences of racism into the therapy room. And whilst this is obviously, you know, a little tongue-in-cheek, I think this raises a really valid point around potential harm in therapy, that if we're adhering to these models, it can actually really undermine people's experiences of racism and like put the onus on them to just like feel differently about a horrendous systemic issue like racism. I read this paper again the other day, which is essentially looking at the factors which are relevant to a person's own sense of recovery and shock. There were differences for people coming from BAME communities. They found that things like faith and religion and collectivist identities were more prominent, but one thing that was major was their sense of stigmatization. There was a lot of stigma that came with having mental health issues, but they were also feeling stigmatized because of their race, their culture, and their ethnicity. This is the part that really got to me, which said that individuals from ethnic minority groups saw themselves as recovering from racial discrimination, stigma, and violence, not just a period of mental illness. And I just thought this was so powerful because, like, if we don't have a proper sense of what recovery means to that individual, then like, how can we support them properly? But also B, if this sense of like race and stigmatization is so intertwined in that person's conception of what it means to be recovered, then we need to be able to have these conversations and to bring people's identities into the room. And I think touching on this, I loved this tweet from Accidental Activist. And I do agree that so many of the models don't actually make much space to think about these things, which obviously then impacts how we assess people and the questions that we ask. So I think as therapists, we really need to take like an active role in developing our own cultural competence and making sure that we're talking to people who know more than us. So for example, in reading this paper, I feel like I've just touched the tip of the iceberg in terms of understanding the work of Black psychologists and the approaches used to understand the experiences of individuals from African descent. And I think it's that constant education which makes you realise that the models that you are trained in may not be the best models to work with the person that's in front of you, and like what else do you need to take into account so you can really best serve their needs. And I think when it's like, if you come from a Western-centric view, it's again the idea of like, hold that position really lightly and make room for these other models, because I think when we bring them all together, we've got so much more of like a better chance to help as many people as we possibly can. I think finally, I thoroughly enjoyed this tweet, which gives all of us therapists an in terms of how to talk about intersectionality from the get-go, because I think like it really just shows like it doesn't need to be that difficult. We don't need to make these conversations so hard if we just maybe look to people who know more than we do. As therapists, our research and academic interests are naturally going to centre around the experiences of real people. And it's not just any experiences, these are usually the most difficult and most traumatic ones of people's lives. And I think the risk of harm here comes from the fact that when you're studying something or researching something day in, day out, it's kind of almost impossible to not become somewhat removed from the experience of the individual, and also to get a little bit desensitized to the information that you're talking about. And I had a real experience of this the other day. So I was working on a video and it was taking ages, and I was talking to my housemate about it, and I was like,
oh, I don't mind too much if it's taking over my weekend because it's literally on my favourite subject.
And she turns around and she's like, oh cool, like what's your favourite subject? And I was just like, childhood trauma? And I caught myself there and I was like, Miranda, like, what do you sound like? And I think it's all well and good to have passion and enthusiasm for a particular area, but I think it's this idea of like, hey, we are still talking about something pretty awful, so just can you calm it down a notch? A tiny bit, maybe. But I think my real point here is that when we're wearing our professional hats, the motivation behind your interest is never really that clear. So say in my case, like, my favourite subjects in psychology are my favourite because of entirely personal reasons. But for a client or a prospective research participant, they're not going to know that. And actually, does your enthusiasm and passion for a subject maybe come across as this like weird intellectual curiosity around their pain? And I do feel like this is way more pronounced in research settings. So I'm at the moment recruiting for my study, and I was recruiting from this particular group, and I sent a message in and I got this in response. And of course, whilst I don't know the ins and outs of this exchange, if you don't make your compassion really explicit, you can make people feel like they are this like strange biological rarity that's really exciting to study. I suppose solution-wise, we can only really get around this by making sure that we are having conversations with people who sit outside of our little psychology professional bubble. Because I think in doing this, speaking to people who aren't mental health professionals, for me it is a really good reminder that the things that I can talk about really comfortably are just, it's just not that easy for other people. So to just make sure that you're going slow.
Just calm down.
And I think from a research perspective, it's just that reminder that it's so important to involve people who've got lived experience as much as we possibly can. Because as the old saying goes, like only the wearer of the shoe will know where it rubs, and they will be best placed to tell us what's okay and what isn't. So the final area I really want to think about is therapist behaviour online and the potential risks associated with this. And I think this makes me the most nervous because technology is developing at such a rate, it's so ubiquitous, and I think for that reason we are probably lagging somewhat far behind in terms of really knowing the ins and outs of what's safe and ethical practices online. And so Erin Stevens, she is really prolific on this subject, and this is the beginning of one of many very interesting threads about this. And I think essentially what she's highlighting here is this idea that it is not okay to talk about your clients ever,
in any capacity,
even if they are completely anonymous. And this gave me, some food for thought, because I think for all of us, we're taught about, really anonymizing, making sure that there's no identifiable information. And if this is the case, then, maybe what's the harm in talking about this online? But actually, through the discussion that came from that, like what I learned is, well, number one, the person who is being written about could probably still identify themselves, and how exposing would that feel to kind of have your information online being talked about? And also number two, for people accessing mental health services, like, would it not be quite off-putting to see that therapists discuss that kind of information and put that on their own profiles? And this kind of made me think about the things that you commonly see therapists talking about. And this is not to throw shade, because I definitely think we are all still massively learning. But you do see quite a lot, people saying like, oh, I had a great session with X person, or Y person has come so far and been able to go from this place and overcome this difficulty. And that is so lovely and positive. But I also feel like there's probably issues there as well, because I think for me, if I were the client reading that, like knowing myself, like I am such a people pleaser and I'm really sensitive to evaluation, I love to perform, and if I saw that kind of stuff, like would that really feed into this notion of like how to be good at therapy and to do well for people and to perform for them? And I know that it definitely would for me. So I think the take home, and one of the key reminders that Erin puts out there, is basically just like, your online presence, like, it's completely in the public domain. And I think if you have a sense of, actually, there's one or two people that I wouldn't want to read that, maybe just don't put it out there at all. And I think this led me on to think about, you know, for people putting educational material out there, like myself, you really can't control who your audience is. And I think this is an issue because when things go online, you can't cater and adapt your tone and your content to meet the needs of the person that's in front of you, because it could be anyone. And, you know, for me, if I'm thinking about producing some material on anxiety like I have, I would talk completely different to a room of undergraduate psychologists who I'm trying to get really excited about clinical psychology, to how I would speak to someone who is in the middle of a really difficult emotional situation and feeling highly anxious as a result of it. And yet, I just have one video that can kind of be accessed by anyone. And actually, how does that feel for the different groups who are watching that? Is that a problem? So I think my main anxiety here, if I'm just distilling a little bit, is the fact that mental health is not a neutral topic. And actually, what you produce and the information that you put out there might be really fine and digestible for one person. It could be triggering for the next. And just like, I don't know, I just feel like uncomfortable with the idea of making anyone upset by the things that I'm talking about or how I'm delivering it. But in a way, it almost seems inevitable because, like I said, once you put it online, you can't really control who accesses it. And I think then it's like, what is the solution? Because it's like, is the onus then very much on the individual to just decide what kind of content they want to interact with? Is it enough to just put a health warning or a disclaimer? And just like, I don't know, the more I think about it, it just doesn't feel like that's really cutting the mustard. And this is the point where I'm realizing that I have way more questions than I have answers, so a really unsatisfactory ending for everyone, I'm sure. Okay, before I teeter too close to the precipice of existential crisis following that last section, I'm going to wrap up today's video. Thank you so much for listening. I really hope you enjoyed today's discussion. I do just want to emphasize before I shoot off that obviously these are very much my initial thoughts and formulations on what is a huge and important subject. I do not in any which way profess to have covered the entire thing. So if you guys have any comments, thoughts, suggestions, signposting to relevant information and resources which might be useful to keep the conversation going, I'd be so keen to hear from you, so please do shoot anything in the comments section below. Okay, enough from me for another week. Take care of yourselves and I will speak to you next time. Ciao for now.